Hello, my name is Dr. Vera Rigolin. I'm a cardiologist here at the Bloom Cardiovascular Institute at Northwestern Medicine in Chicago. And I'm here with my colleague, Dr. Jyothy Puthumana, and we are at the 41st Annual Echo Northwestern Conference being held here at Northwestern Memorial Hospital. We have a lot of exciting topics that we're covering here at the conference, and we're only going to talk about a small fraction of what we're covering so that we hope that you will be here with us next year so that you can hear the rest of the story. But I'm here with my colleague, Dr. Puthumana, who's also a cardiologist at the Bloom Cardiovascular Institute, and he is the director of our interventional echo program. And Dr. Puthumana, I want to focus our discussion on the tricuspid valve. Okay. And as you know, the tricuspid valve has often been forgotten, and more recently we've realized how important the tricuspid valve is. And can you tell us from an imaging standpoint, why is the tricuspid valve so hard to image?
I think, thank you for the introduction. The tricuspid valve, for multiple reasons, I think we did not emphasize on it during these years of evaluation. The patients who are coming to us were either too far gone with tricuspid regurgitation, so I think, but a bulk of the patients that we were seeing, the present imaging modalities didn't do a good job of giving us visualization of all the three leaflets, did not give us enough information to be able to clearly quantify the severity of it. So we were either not able to say what the grade of tricuspid regurgitation was. And again, as we know, the tricuspid valve is multiplanar, so even with 3D imaging, the tricuspid valve leaflets are not uniformly seen. And also, as we see, most of our patients with tricuspid regurgitation are older patients who are where it's due to left-sided heart disease, and these are patients where the valve leaflets tend to be thinner. Most of the 3D development, both in 2D, both in transthoracic and transesophageal, initially was targeted to the mitral valve, the left-sided structure. So I think the tissue characterization again was not well defined enough to see all the leaflets, the annular structure, and which is why I think we are now in a great phase of getting a lot of information because we are being forced to do it, since these patients seem to have more options potentially for treatment.
So thank you. Dr. Puthumana gave a really great lecture at Echo Northwestern this morning, and main things that he emphasized is that the anatomy of the mitral valve is really variable. We think of it as a valve with three leaflets, but oftentimes, as you point out, it has more. Yeah. Sometimes it has four, sometimes it has five. So the anatomy can be really variable. It's an anterior structure, so from a transesophageal perspective, since we're imaging posteriorly, anterior structures are more difficult to see, and so visualization can be challenging. And our quantification is not as well studied as it is from the mitral valve. Yeah. And so we don't have as much data to tell us exactly what the cutoff values are for quantification. However, with more and more research in this, we're seeing how important it is, yeah, and getting more experience. And as you point out in your lecture, it's really important to be very descriptive and very quantitative when we report tricuspid regurgitation, yeah, in our reports. Yeah. And then you also talk a little bit about the differences between functional and organic tricuspid regurgitation. Yeah. Can you tell us what the difference is and why that's important?
Okay. So primary or organic MR is TR are patients who have tricuspid regurgitation because of abnormality of the tricuspid valve, which ends up being actually a very small portion of patients, about 15-20% at most. These are usually patients with congenital abnormalities, or in some patients with acquired abnormalities. These are patients who have pacemaker leads, defibrillator leads, and so forth, or patients infective endocarditis. These are the organic tricuspid regurgitation where the valve is the problem. But the bulk of patients that we see are patients with functional tricuspid regurgitation where the valve, the annulus, the right ventricle has remodeled in response to abnormalities, usually on the left side due to left-sided valvular conditions, or due to pulmonary arterial or pulmonary venous hypertension that manifests itself in the right ventricle, causing right ventricular dilation, annular dilation. And the other thing that we underestimate is the number of patients with atrial fibrillation who present due to right atrial dilation that leads to annular dilation and then present with tricuspid regurgitation. So I think the bulk of our patients are functional tricuspid regurgitation patients with a small number who have primary or organic tricuspid regurgitation.
Yeah, and it's interesting that you bring up the atrial fibrillation population. I think that that's a really a huge population that we deal with, and I think it's underappreciated how much functional tricuspid regurgitation you can get from atrial fibrillation. And in many cases, the right ventricle may be normal, but the right atrium is really large. And if you think about it, it makes sense. The annulus sits between the atrium and the ventricle. So if either chamber dilates, it can affect the annulus and then cause functional TR. Yeah. Okay, great. And then you mentioned in your talk a lot of new treatments for tricuspid regurgitation. Can you highlight a few of the emerging therapies for tricuspid regurgitation that weren't available a few years ago?
Thanks for this. We are kind of lucky and excited that we have been involved in novel research therapies percutaneously for the tricuspid valve now maybe for 4 or 5 years, starting off with the procedure called SCOUT, going on to using the Pascal device and Cardioband, and now we'll start to be part of the Triluminate trial. And it is exciting insofar as we are seeing a lot of patients luckily being referred to us to be evaluated who are not surgical candidates. And what we find is that as we see more and more of these patients, definitely our sonographers are getting better at evaluating these patients. We find that a lot of patients are coming to us closer to the end stage of disease, where maybe they are too far gone in their disease for options for treatment. But what we have getting a lot of experience with is therapies that either address the leaflet, and the two trials that we are part of includes the Edwards Pascal trial using the Pascal valve, and now we are going to be part of the Abbott sponsored MitraClip for the tricuspid valve. So these are the two trials that address the leaflet. The trials that address the annulus is the Cardioband device, that is an Edwards device that we have a lot of experience with. Again, these are long procedures, but it is an exciting field that the newer modalities are aiming to increase leaflet coaptation, decrease annular dimension, and kind of cause cinching. So the newer technologies, again, we are at the infancy of knowing from an imaging standpoint, from an interventional standpoint, and outcome, even patient selection. When we looked at the earlier patients, there were patients who were probably a little too sick, but I think we seem to be getting better at choosing the right patient for the right device.
Wonderful. So it looks like we have a lot to learn, and the future looks promising, and we can't forget about the tricuspid valve anymore, right? All right, well, thank you very much, Dr. Puthumana, and thank you for your attention. Again, we're here at the 41st Annual Echo Northwestern Conference. If you're unable to join us this year, hopefully you can come next year and learn more about echo imaging with us. Thanks for your attention.
Thank you.